I'm going to take a little liberty with the title and talk about advanced stage disease, and add a few additional information on relapse patients. I think that here are my disclosures. Have research support from a number of companies, and I'm on the scientific advisory board on these that are listed. So questions I'll talk about are the 5-year echelon 1 results convincing to consider BV-AVD the standard of care for advanced stage Hodgkin lymphoma? What's the optimal management of patients who are older than 60? And importantly, what is the impact of primary treatment as that changes on second-line therapy? So how do you treat advanced stage Hodgkin lymphoma? First, many of the studies include poor risk early stage disease, stage 2A and stage 2B. And I want to remind everybody that's not advanced stage Hodgkin lymphoma. As far as what I learned, it's stage 3 and 4 disease. For example, the Rathel study, 40% of the patients had early stage disease. So do you give ABVD times 6? Do you use escalated BIACOP? Do you give BV-AVD? Do you do PET-adapted therapy starting with ABVD? Or do you do PET-adapted therapy starting with escalated BIACOP? So I can't say that there's been significant updates in any of these studies. They may be at the Cologne meeting in a few weeks. But if you look at the starting with ABVD first in PET-adapted treatment, in the US intergroup study and in the Rathel study, early on at 2 and 3 year follow-up, about let's give or take 80 to 85% of the patients have done well in the first curve. I will say that we updated the SWOG data, and pretty much that information is about 76 to 77% of patients are doing well. The numbers have come down. What is interesting, though, is that in patients with PET-avid disease, in general, with changing therapy to escalated BIACOP, give or take a few percentage points, about 62 to 63% of patients are doing well. So in patients, if you're going to do PET-adapted therapy and the PET scan has a Doble score of 4 or 5, it's not appropriate to continue ABVD. The plan, of course, would be to change to escalated BIACOP, and there's upwards of a 2 out of 3 chance that those patients will do well. I will say I don't do that anymore. A number of years ago, I was practicing that way. The French have done the flip, where they've started with escalated BIACOP for 2 cycles, and in patients with PET-avid that were PET negative, they crossed over to ABVD, and there's pretty long-term follow-up in this data set, and about 84 to 85% of the patients are doing well. I was doing this particular treatment for a number of years in patients with 3 to 7 risk factors. I've also stopped doing this treatment. I'm not a big fan of escalated BIACOP. I think everybody needs to get transfused. The patients are pretty miserable, and there are better treatments. People ask me all the time, should one give radiation therapy for patients with bulky stage 3 or 4 disease? There was never any evidence that improves survival. I think this is an excellent paper from the Italian Lymphoma Study Group, where they looked at consolidated radiation therapy in patients with advanced stage disease. If you concentrate on the right panel here, everybody started with ABVD, and if the PET scan was negative after cycle 2, and negative after cycle 6, then there was a randomization for patients with a single nodal mass of at least 5 centimeters to no further therapy or to consolidated radiation therapy. And you can see that all the curves are the same based upon the size of the mass. So there is absolutely no role for radiation therapy in patients with advanced stage Hodgkin lymphoma who are PET negative after standard chemotherapy. So the dilemma in therapy for Hodgkin lymphoma, however, is that it's clear escalated BIACOP improves progression-free survival over ABVD, but is much more toxic. And BVAVD, which we'll discuss now, as far as toxicity, falls somewhere in the middle. Is BVAVD the standard therapy now in the US? First, I want to digress and say that in patients who are PET2 positive, when you start off with ABVD and switch to escalated BIACOP, there's absolutely no evidence that you should switch to either BVAVD, Pembro AVD, or nivolumab AVD. No evidence. That is not something that should be done. If you're going to do PET-adapted therapy and you're starting with ABVD, and the PET scan is positive after cycle 2B, then patients should get escalated BIACOP. So this is the Echelon 1 study, well-designed study, not my favorite study, but well-designed. Everybody either got 6 cycles of BVAVD or 6 cycles of ABVD. There was a number of PET scans that were done. Scores 4 or 5 were considered positive. There's a lot of CAT scans and PET scans done for a number of years thereafter. And as you know, this was originally published in New England Journal of Medicine a few years ago and was most recently published again. It's a very well-balanced study. And as you can see, it's only for patients with stage 3 or 4 disease. So by definition, the results with ABVD are going to be probably not as good as they were in the Rathel study, because that study had more patients with early stage disease. What's also very interesting is that if you look at the PET2 status, less than 10% of the patients were PET2 positive. That's a contradistinction to a number of other studies where upwards of 15 to 20% of the patients are PET2 positive. And what has happened as we've moved along now at 6 years, and I will say that I was pretty shocked at this, there has an overall survival advantage with BVAVD over ABVD of about 4.5%. Now, quite frankly, there have been a lot of folks out there that were resistant to change from ABVD to BVAVD based upon endpoints that were either modified progression-free survival or progression-free survival. But at this particular point, I think the question is answered. There's almost no studies in Hodgkin lymphoma that I can think of, other than going back 25 years ago, comparing escalated BIACOP to COP ABVD, neither of which we're giving, that shows an overall survival advantage. So here we have one. And from my point of view, this is level 1 evidence that BVAVD should be used as standard of care in patients with stage 3 or 4 disease. There's a benefit in all groups based upon the forest plot. This is the progression-free survival curves. And what's very interesting here is if you look at the ABV arm, it's at 74.5%. Well, that's exactly the data which is in the SWOG US intergroup study at 5 years. So remember, as when you're treating advanced stage disease, the results of ABVD will go down. As far as deaths on study, there are more deaths from lymphoma on the ABVD arm, and the side effect profile is about the same. As far as toxic death, of no surprise, in general, patients were able to be salvaged with either regimen. There were fewer secondary malignancies on the BVAVD arm, but what's very interesting is that the most common malignancy in the ABVD arm is diffuse large B-cell lymphoma. Many people were concerned about pregnancies after BVAVD, and whether you believe this data or not, it seems clear to me that both BVAVD and ABVD at worst are the same. as far as live births thereafter. Obviously, there's more peripheral neuropathy with BV-AVD. These are my conclusions of this program. Others may have different conclusions. It's the first regimen to show an overall survival advantage over classic ABVD. Despite, and surprisingly, with all of the salvage therapies that are available, there's still an overall survival advantage, even with checkpoint inhibitors. There's fewer second malignancies, stable pregnancies, peripheral neuropathy is improving, and I believe it should be standard of care. Now we have some newer treatments out there. One is Nivo-AVD. This is the original phase 2 study, which was published in the JCO, which has never been updated, which was induction nivolumab for 4 cycles and followed by 6 cycles of Nivo-AVD. The curves are okay. They were coming down. I would have been interested to see if there were late relapses, but once again, not updated. This is the data from Emory and Northwestern, a very small study of Pembro-AVD, where there was induction pembrolizumab, followed by AVD with a PET, and then more AVD. And according to this group, all 30 patients are in stable remission. As you may or may not know, almost finishing is the United States intergroup study of BV-AVD versus nivolumab and AVD. We've put about 20 patients on this at Miami. All of our patients are doing well. As of last count, I think there are about 900 patients on the protocol. How do I treat advanced stage Hodgkin lymphoma? Well, I enroll patients on the national study. Off protocol, I give BV-AVD for stage 3B and 4 patients. I think for I think for patients with stage 3A disease, these patients have no IPI risk factors. I still like giving PET adapted therapy. For patients older than 60, I'll show you some data in a minute. I do not give standard BV-AVD. And let's remember that even though the topic of today's conversation was what to do with PET adapted therapy, we now have an overall survival advantage with a program that's not PET adapted. So this was a recent update of the Pembro-AVD study with some correlatives, longer follow-up, just showing that this program has durable remissions. What I found very interesting, and I'm sure you know, I got pembrolizumab approved internationally for Hodgkin lymphoma, and in the relapsed and refractory setting, and we saw a 28% CR rate. This is the data looking at single agent pembrolizumab, 3 doses in the untreated setting, and one can clearly see that the CR rate is really very high in the untreated setting, based upon the plot on the left. And nearly every single patient responded. And there was responses also in patients with tumor bulk. And this is, of course, associated in advanced stage, as I'm sure most of you know, is enriched for the 9p24 genetic abnormality, which defines the role of checkpoint inhibition in Hodgkin lymphoma. Here's the updated information up to 3 years now in this study. I like this particular study. I don't know where it's going. I think there's an industry study being led by Merck comparing Pembro-AVD to ABVD. Now, at this last ASH, there was a concurrent Pembro-AVD study, not sequential, done by the Hutch. Somewhat of a complicated program, but suffice to say that everything was given combined. Well-balanced study. Unfortunately, had early stage patients here, which of course, as I said before, to me, do not count in advanced stage Hodgkin lymphoma. What was interesting is that if we just go through the schema for time constraints, 29 out of the 30 patients did well. And as expected, I am a Pembro fan over nivolumab. But if you look at almost every single cancer that is where both pembrolizumab and nivolumab are approved, pembrolizumab is slightly better than nivolumab. Now, in patients older than 60, a study that we did when I was at Sloan Kettering is as such. So I think most people know that bleomycin in patients older than 60 is really fraught with difficulty. And if you look at ABVD versus Stanford 5, patients older than 60 are on the bottom curve here. And many of the events were without progression, just related to toxicity. 43% of the patients had bleomycin-induced lung toxicity. So there's been a number of studies that are looking at adding, starting off with single agents and adding new drugs. I personally don't think this is ethical. I'm older than 60 now, and I would like to be treated with curative treatment. I don't want to get BV alone. I don't want to get BV and bendamustine. I don't want to get BV and dacarbazine. So what I want to get is sequential BV-AVD. And what that is induction brentuximab vedotin, followed by a PET scan, followed by AVD, followed by some additional brentuximab vedotin. And the reason is that these results are almost identical to concomitant BV-AVD, and is very well tolerated, much better tolerated than concomitant BV-AVD in patients that are older. So this is my favorite program with brentuximab. How do I treat advanced stage Hodgkin lymphoma? As I said here. So I want to just go for a second and present 3 short cases. And the reason I want to present them is that they're all relapse patients. They're all my patients. They're all treated differently because of different upfront treatment. The first patient is a 37-year-old internist who I'm taking care of now, presented with stage 4 disease, treated with 2 cycles of BV-AVD. The interim PET was Adoval 3. She got 4 more cycles of BV-AVD and had a residual lymph node in the neck with Adoval 4. I saw her at that time and recommended to repeat the PET scan in 10 weeks, which we did and showed progression. And I placed her in the Pembro GVD study that we have. This is the study which was published by Allison Moskowitz and myself in the JCO last year and will be updated at Cologne. 4 cycles of Pembro GVD, and that was followed by a stem cell transplant. The current study is no transplant if you're in remission and a year of Pembro maintenance. But suffice to say, and I've been studying relapsed Hodgkin lymphoma now since 1994, when I wrote the first ICE program. This particular study has the best results that we've ever seen in 30 years. In the 39 patients that we treated on this protocol, there's only been 1 event, which is why we thought maybe we're overtreating the patients and let's remove the transplant and give Pembro maintenance if patients are in remission. And that study is almost complete, and we presented at Cologne. Now, this lady is on study. She had 2 cycles of Pembro AVD. The PET scan was negative. She got 2 more cycles, continued to be negative. She had thyroiditis, as can be seen in this PET scan over here. And she just got dose 7 of Pembro maintenance. Here's a second case. It's a 27-year-old medical student that I'm taking care of, who was treated with 2 cycles of ABVD. The interim PET scan has Adoval 3. Got 2 more cycles of ABVD at that time. PET scan 1 month later, Adoval 4. Same scenario, repeated the PET scan 10 weeks later. Had disease progression. This patient never got brentuximab vedotin before, so we put the patient, we gave the patient BV-Nivo. And as you know, this is we've published this a number of times right now. The waterfall plot is negative, but I want to show you here on the right, on the top curve, In patients who have a complete response to BV-Nivo and then get a stem cell transplant, there's only been one event. And here's the last patient of a patient who had bulky stage 2 disease on ABVD. I saw in consultation at the time. He lived in California. It was going to be difficult for him to get treated by me, so I recommended that he get ICE chemotherapy. He got 2 cycles of ICE chemotherapy, had a complete response. We transplanted him and we put him on the Athera study, which is sort of like falling out of favor these days. Did have an excellent response. Then he progressed with disease on the left. He put him after BV maintenance, he progressed on this imaging study. The options were to give him a checkpoint inhibitor or radiate. We wound up radiating him, and he was in remission. And then he wanted to go on a checkpoint inhibitor. So we put him on a checkpoint inhibitor based upon Philippe Armand's data, and he's doing well. So I know that that's a lot of information in a short period of time, but I'm happy to answer any questions. This is our group, and hopefully we can see each other in person soon. Thanks for your attention.